Welcome to the Codecast Podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the Codecast Podcast today. My name is Terry Fletcher. Hello to all of our 30,000 plus listeners. We are growing on YouTube, all platforms, including iTunes, Stitcher Radio, Spotify, Google Podcast, and TuneIn. Happy to have you here today. What my plan was today was to actually talk about some remote coders and really how you can be a coder from home and things like that. And I am going to push that a little bit only because in the last 24 hours, and obviously because we're now into January, in the first and second week, we have some confusion over what is the reality of the E&M changes. What went into effect for evaluation and management services, what got pushed until 2021. And there's a lot of confusion out there and misinformation. And so this to me is almost like a news alert. Here is the reality, giving it to you straight, letting you know exactly what was updated or what you're in for 2019, and then what to expect for the future. So you can also see it on my website at terryfletcher.net. I did a big blog about it, so just make sure you're reading up on it and you're getting the correct information. Make sure that you're not dealing with some of the misinformation that's out there, because it could really hurt you if ever audited. So the first thing we want to get to, and when we look at this, is making sure that you're understanding that Medicare and AMA, which is the CPT book, they're sort of on the same page. So what Medicare put out, they almost in effect kind of disregarded the CPT book, saying, well, this is what we're going to do, and we're going to kind of ease the guidelines just a little bit. But when I tell you about the actual reality of the slight changes that were made, then hopefully you'll see this and say, okay, I can handle this, I can incorporate this into my practice, and I just need to clarify with the physicians. But first, today the Codecast Podcast is brought to you by Movado Watch Company, one of the world's leading watchmakers. Movado, modern, ahead of its time. Movado.com. Also check out their new affiliate, MVMT Movement Watches, at mvmtwatches.com. Also, Healthcare Executive. Healthcare Executives Network is the fastest growing community for healthcare executives and their trusted partners. healthcareexecutivesnetwork.org. Okay, so as I get into some of this information, I want to tell you about so when I really look at this from a narrative perspective, how you can go back to your practices and say, here are the bullet points, if you will, of what we can expect for 2019. And so because there's so much confusion that the levels were changing and all this kind of information, that's not accurate. The changes to the levels of the E&M services and the single payment reimbursement does not occur until 2021. Okay, so it doesn't occur now. Everything is also spelled out in the link cms.gov/newsroom/fact sheets. And this is the final policy payment and quality provisions, changes Medicare fee schedule for this calendar year. So you can always look it up as well, but I just want to give you the kind of the skinny on it so you know what's reality and then what everybody else is saying. So what we're looking at is that 2019 and 2020, they really do not reflect anything different from what's already required and has always been required, except really for the elimination of the requirement to document the medical necessity of a home visit in lieu of an office visit. So what I mean by that is before 2019, to be able to justify a physician going to a patient's home, they would have had to document why the patient was housebound or why their condition warranted a home visit. It wasn't something that they could just say, well, I offer a home visit so I can go to their house. There had to be a specific medical necessity reason behind it, but no more. If your physician wants to go to a patient's home and treat them at home, that's their option. There doesn't have to be a difference between the medical necessity of an office visit in their clinic versus going to the patient's home. Now, the next 3 bullet points, and I do it by bullet points just so you have it, and you can listen to this back so that you can play it for your physicians if you like as well. And again, the transcript, I did this on purpose, of this is on my website under my blog heading. So for established patient office visits and outpatient visits, when relevant information is already contained in the medical record, practitioners may choose to focus their documentation on what has changed since the last visit or on pertinent items that have not changed. And here's the part that they say has been updated. It says, and need not re-record the defined list of required elements if there is evidence that the practitioner reviewed the previous information and updated it as needed. Practitioners should still review prior data, update as necessary, and indicate in the medical record that they have done so. So the thing is here with this bullet, you're still required to show that you looked at the data from before. You can't just say it's there and not comment. So however you make that happen, reviewed and agreed, review at the above, no changes since, or there are changes, you still have to acknowledge that the patient was actually revisited, if you will, to that information, because this is for established patients. And so you want to make sure that you are updating that information. And then it goes on to say, and this is the third bullet, additionally, we are clarifying that for E&M office and outpatient visits for new and established patients, so this is new now and established, for visits, practitioners need not re-enter the medical record information on the patient's chief complaint and history that has already been entered by ancillary staff or the beneficiary. The practitioner may simply indicate in the medical record that he or she reviewed and verified this information. This bullet I have a little hard time with. I have to bring it to you because that's the legalities as far as what has been updated or what hasn't been updated. However, when you hear what I say with that, I really want you to, just from a compliance and best practices standpoint, remember, you're being scrutinized no matter what you do. You're being looked at. So when it says you don't have to re-enter the medical record information that's already been entered by ancillary staff, but you do have to indicate that you've reviewed it and verified it. And again, that's always been required. So to me, when that wasn't really a change, as they stated, this is just clarifying. Let's just say you have a patient that comes in. I was actually talking to Desastin about this last night. My one collaborator, he's also my music producer, and we were having a conversation about this. And this is why I wanted to podcast, because we're really good about just getting some of these ideas and talking about how it really incorporates into the healthcare field from a reality standpoint of being in a physician's office. So we were role playing, and I said, okay, so you're in a doctor's office and you're giving your chief complaint and you're talking about what's happening with your body and your illness and everything. Well, if you're having an ancillary staff person, such as a medical assistant or an RN or, somebody that's not a mid-level or a physician, basically the person putting you in the room, they're going to ask you, okay, so why are you here, or confirm why you're there based on why the appointment was made. And you're going to give them a 1, maybe 2 sentence answer. I'm here for chest pain, or I'm here because my shoulder hurts. But you're not going to elaborate on that chief complaint. So what we were discussing is I said, now the doctor steps in the office. And now when the doctor steps in, because nobody wants to repeat themselves, okay? Think about when you get on the phone you have a bank issue or you want to make an airline reservation and you don't want to have to keep getting transferred to different departments. It's kind of similar when you walk into a doctor's office and you're put in a room by an ancillary staff, which is a lower level staff. You're going to give brief information because you want to only have to talk about your condition in detail once. So what you want to do is that when the doctor comes in, now you're going to say, actually, I have chest pain, I have shortness of breath with it as well. But the doctor, because they're a doctor, or again, a mid-level provider, they know what to ask the patient. So with this chest pain and shortness of breath, do you have also tiredness, fatigue, pain, wheezing, coughing, headaches, anything that is going to possibly change or make a difference in your clinical profile. Same thing with just simple, shoulder pain or knee pain. Do you shoulder pain? Do you get headaches with it? Is it radiating up into your neck? Is it going into your head? Is it radiating down your arm? Are your fingers going numb? A staff member is not going to ask that because they are ancillary. They're there to put you back in the room, get basic information, and then move to the next room with the next patient. So going back to this bullet about what is clarified as far as what has to be documented, no, you don't have to re-enter the shoulder pain. You don't have to re-enter the chest pain and shortness of breath, but you do have to reflect that you reviewed it, you verified it, and hopefully you expanded on it. And I wish they really put that as part of the rule. But this is what I would look at. Remember, I'm an auditor, not just privately, for practices that contract with me to do, their audits every year, but also for Medicare. And so that's what I would look at. I'd say, okay, well, where's the rest of it? So I just don't want physicians to feel like this is their out to not have to document, that they can just have their ancillary staff do everything. And that's not the case. And then the last bullet, and this one is a little bit of relief, removal of potentially duplicative requirements for notations in medical records that may have previously been included in the medical record by residents or other members of the medical team for E&M services furnished by teaching physicians. So that's different. That's in a teaching facility. And a lot of times, because they're proctoring the residents, they're having to re-enter a lot of the information. They don't have to do that now. So basically, they're saying that residents are de facto physicians and you can trust what they say as long as you follow the teaching facility guidelines and either agree or disagree with their information, sign off on it with a salutation that, I was directly involved in the patient's care. And so that part is different. But you'll notice that's it. That's what was changed for 2019. We are still using the current coding and payment structure for E&M office outpatient visits and for the 1995 or 97 E&M documentation guidelines. So we still have to use those. That has not changed. I don't know if anybody told you that changed. It has not changed. Now, when we talk about, I saw a couple of erroneous comments where you can just use time as your constant. That's coming in 2021 as far as picking a level of service. And what I mean by that is, yes, you can use time now if 50% or more was spent counseling, but you have to say that. And then the other thing was somebody had just put out there, I think it was E&M University, which I really like that site, but sometimes I call them cowboys. They push the envelope just a little too far, where they said on their site that you can use medical decision-making as the only criteria for picking a level of service. Well, that is a possibility for 2021, but not now. Medical decision-making still drives your visit code, meaning that that is the overarching factor. And, what are you going to do with this patient? If you're telling them to go home, rest, and gargle, or go home and take over-the-counter medication, it's hard to say this patient is a high-risk patient. But if you're going to have to order tests to work them up further to determine what they need to move on from diagnostics either to surgery or procedures or anything, then yes, that makes sense into more of a higher risk or moderate risk patient. So, but when I see those things on, and it's, what I like to call it, and it's really frustrating for me, I call it clickbait. And I'm not picking on that site because I think it's a decent site. I just think that you have to be careful with clickbait. It means click on this and we're going to give you half truths and tell you what's sort of true. But I never do that. Absolutely not. I want to give it to you straight and say, okay, this is what's accurate. This is what's going to be pushed. And this is what you have to do now, because let's face it, we don't have time for all the other nonsense. We just don't. We have to make sure that what we're doing is accurate now and we understand what's going to be later. So specifically for calendar year 2021, CMS is finalizing the following policies. And you hear how I worded that, finalizing. They're not final yet. This is what is being talked about. This is the situation. So reduction in the payment variation for E&M office outpatient visit levels by having providers pay a single rate for E&M office visits level 2 through 4 for established and new patient visits, while maintaining the payment rate for E&M visit level 1 and 5, and they say it's to better account for care needs of complex patients. Permitting practitioners to choose to document E&M office level 2 through 5 using medical decision-making or time instead of applying the current 95 or 97 guidelines. Or you can use the current framework. But that's going to get tricky because, again, it's only for outpatient office visits, inpatient visits, consults, anything that doesn't fall under outpatient office visits, you're still going to have to document like you always have. So you're going to have 2 sets of guidelines, 2 sets of EMRs, 2 sets of templates. It's to me, it's not a positive. And then the other part is beginning in 2021, Office visits level 2 through 5 will also have some flexibility in how they're documented. Again, you can use medical decision making, time, you can use other issues with required to information from the history and exam, and then push for the medical decision making. If you're going to document time, you'll have to reflect the medical necessity of the visit and why that required amount of time was necessary. There'll be some add-on codes for additional resources inherent to visits, not just for primary care, but for specialized care. And there'll be a new extended visit, which means there'll be something else you can add on. I think it's worth about $14 right now is what it's looked at, as far as needing to spend, again, more extended time with the patient, required to maybe coordination of care or setting them up for their tests or their diagnostics. So there are going to be some things that you're going to be able to do come 2021 that they're taking a look at. But the thing that you have to really be careful of here, and I'm dealing with this with actually a particular audit I'm working on right now, when I see practices say, oh, great, I can just use time. And I may have mentioned this before in a different podcast. I know last week we did new and established patients. Time is fine when you're spending, to me, counseling the patient. It's a discussion visit, and you're having this lengthy discussion, and you've concluded how much time, 50% or more, is spent counseling to really get them to understand their clinical profile and what they have to do moving forward. What I don't like to see is everybody getting excited about time and not understanding not just the reimbursement ramifications of this, but understanding what it's going to do to your practice. So let's say that you've decided you're going to use time as a factor, that you don't want to deal with all the E&M guidelines, all the different things and nuances that are coming up. Okay, well, if you're going to use time, if you're going to say that you spent 60 minutes with the patient, that's what gets you to a level 5. Are you really going to only limit yourself for a 4-hour clinic to 4 patients? So you're limited when you use time. Again, I'm not saying you shouldn't use it. I'm saying be aware that there are some factors when you use time as your constant that may limit you on what you can do. And that's where I just want you to be careful with that, because that can really just, I don't know, it could just be a problem when people aren't really understanding the factors when it comes to how time can not just hurt you, but it also can limit you on what you can do from your practice reimbursement. We'd like to take a moment to thank Health Tech Magazines, serving forward-thinking professionals involved in healthcare. healthtechmagazines.com. So for my coding question this week, it comes from one of my clients in Pittsburgh. She says, Terry, procedure code 36252 is denying for a diagnosis code. It was billed with our heart cath, and I used angina as a diagnosis. I don't really understand this code, so could you please tell me what code to use and is there a diagnosis problem? Well, 36252, that is a bilateral renal angiography, meaning that your physician is taking a catheter, because it includes catheter placement, moving that catheter, manipulating it into the renal artery or the pulls to the kidneys, that would be the blood supply to those kidneys, and injecting. And typically the diagnosis codes would be for uncontrolled hypertension, aortic insufficiency, renal stenosis. They're going to look at that area to determine if that patient needs to have an intervention, so a stent or an angioplasty or a combination thereof, in that area to open up any kind of blockage or passageway where the blood is flowing through so that the patient doesn't go into kidney dialysis or renal failure. So angina, which is basically a cardiac-related chest pain that's chronically happening for the patient. Chest pain and kidneys are not going to pay each other. So you have to make sure that you're linking the correct diagnosis. So an answer, yes, you're going to probably be using and look for something within the report that is along the lines of hypertension, which affects the kidneys. And if that is the case, then you would be looking at a code in the realm of I-10. Or if you're looking at renal insufficiency, anything in that kidney area, or aortic insufficiency. So make sure you're looking at that, not at a heart condition. So you have to look at those combined services to make sure that you're capturing and linking the correct code for that. So my personal tidbit for today, I have a trip coming up, which I'm pretty excited about. So I'm going to be teaching in Napa. I'm going to be doing a 2-day gastroenterology coding course in April. And so hopefully some of you that want to come up and join me, it's going to be April 10th and 11th. But before that, my daughter will be on spring break she's in her last stretch of her teaching credential to be a high school English teacher. And she's going to be joining me for a little bit of wine tasting up there. And I'm pretty excited because my friend Corinne and her mom, who lives in Arizona, she's going to be coming as well. So we have a mother-daughter dual trip planned, and we're all adults, so which is nice. So just a kind of an adult mother-daughter trip, spending some time in Napa, just enjoying wine and the beautiful setting, and hopefully a couple of good restaurants and a relaxing long weekend for them before I work. So anyway, I'm just excited about it. You know, if you get a chance, or even if your kids are grown, to spend some time with them and they still think you're cool enough to spend time with, take advantage of it, because you just never know when they're just going to be too busy for you. And that day is sad for me. So I'm glad that I have really good friends and I have got an awesome daughter to spend that time with. So everybody go out and just make it a great day, and hopefully you have a good start to your new year. Thank you for listening to the Codecast podcast. And thank you to our collaborative partner, Disassa Music, rapper, writer, music producer. Check out his latest album, MMIL, Meet My In-Laws at DisassaMusic.com. iTunes, Spotify, Tidal, and all streaming and downloadable platforms. DisassaMusic.com.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter at TerryCoder1, or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Disassa Music.